prevent and reduce the number of crises and complications, to treat crises and complications promptly and effectively, and to promote a healthy lifestyle and a positive self-image. So we'll be taking the acute complications. There are three basic types, or most common type, that are known as the sickle cell crisis, and this include the painful or vaso-occlusive crisis, or some people call it bone pain crisis, because it occurs common. So, and this include the other one is sequestration crisis and aplastic crisis. Hemolytic crisis is no longer considered as an entity because the sickle cell disease itself is a hemolytic state, and there's always an ongoing hemolysis, and with varying degrees depending on the individual. But once in a while, we can have an exacerbated hemolysis that could be triggered by maybe infection or following blood transfusion. And in that case, we have a hyperhemolysis, but ordinarily, it is no longer seen as a unique entity. Then we have priapism as a acute complication. We have acute chest syndrome, and we have stroke or acute cerebral syndrome. Sickle cell crisis is defined as a worsening of the symptoms and signs over a short period of time, and is usually associated with pain or shortage of blood. So this crisis can either be pain, mainly pain, or anemia. So like the sequestration and the plastic crisis, they give us anemia. The vaso-occlusive crisis give us pain. Anywhere it is occurring is pain that mainly that will have. And while the sequestration and the plastic crisis will give us anemia. Sometimes we can actually have a combination of this happening at the same time. Steady state is the interval between crisis when the individual is relatively in good health. Comprehensive management of patient in crisis involves treatment of acute clinical problems during the episode, identifying and eliminating possible predisposing factors or triggers, arrangement to ensure continued care of the patient in steady state. So after treating the patient in crisis, it's important to continue to do follow-up. Usually, when they are discharged, you give them short appointment to come back, and then if they are well, you now begin to give them a longer appointment. Most patients, sickle cell patients, will stay at home. They don't come to hospital. It is when they are having crisis, that is when they come. So, but when they come, after treatment, it is important to strictly emphasize to them and the need of coming for follow-up even when they are steady, when they are relatively healthy. It's important to emphasize to them and to make arrangement. If they are not close to where they are treated, let them find a place closer to them to be attending a, a follow-up clinics on a regular basis so that they can be monitored and cared for in order to prevent subsequent or to reduce the frequency of their crisis. So these are the predisposing factors to sickle cell crisis. We have exposure to cold or drenching rain, rainfall, physical exertion, dehydration, injury, including surgical injury, psychological stress, idiosyncratic that is peculiar to the individual, idiopathic or unidentified. Sometimes a patient presents in crisis and you take all the history, ask for all the predisposing factors and you find none. So it's idiopathic. Infections can also, or infestation can also trigger crisis. And for some people, when they take certain drugs, it can trigger crisis for them. So how do we manage patient presenting with crisis? Initial evaluation include history. You briefly take a short history. We should not be preoccupied with this because usually they are in pain or they are almost in shock depending on the type of crisis. So, but you just take a very brief history while treating, while instituting certain intervention. History include the pain or self-assessment of pain and prior treatment before presentation, drug allergies, history of increasing jaundice, and passage of Coca-Cola colored urine. Then you quickly assess the vital signs, blood pressure, heart rate, respiratory rate, oxygen saturation, and temperature. If it is bone pain crisis, you assess the areas of bone that are affected and the tenderness. And the initial treatment include pain relief if painful crisis. Usually, if you've assessed the severity of pain, you know the kind of analgesic you will give. And then once the patient pain is relieved, you can now go back to the clocking or history and properly clock the patient and examine the patient in order to identify the triggers of the crisis. And optimal hydration for patients that are dehydrated, identification and treatment of infections or other comorbid conditions, blood transfusion if necessary, and to address specific clinical problems. So these are also the initial investigations that you want to do. Full blood count and reticulocyte count, very important as they are coming in. You are assessing them briefly. You are instituting your interventions and at the same time, taking the sample, the full blood count in particular, you quickly take the full blood count to determine their counts at presentation. Blood film examination, especially if we are suspecting malaria parasites, plasma bilirubin level, serum urea, infection screening, abdominopelvic ultrasound, if as necessary, chest x-ray, pulse oximetry. Now, chest x-ray is very important. Usually, we know that vaso-occlusive crisis is a predisposing factor to acute chest syndrome, especially the bone pain crisis. There could be a release of fats leading to fat embolism or triggering some coagulation system that can lead to microthrombi and so on. So usually, if we are able to take X-ray at presentation, with time we could appreciate new infiltrates when we are repeating the chest X-ray, especially when we are suspecting acute chest syndrome. Pulse oximetry, very important to know the oxygen saturation. We can also do transcranial Doppler ultrasound, especially in children when they are having CNS features. Computerized axial tomography may be necessary, and magnetic resonance imaging. Yes. So looking at vaso-occlusive crisis more closely, presentation usually we know that it is the most frequent type of sickle cell crisis. It is due to obstruction of blood vessels, which leads to ischemia, infarction, and pain. Yesterday, we saw several ways in which the blood, how the blood vessels can be obstructed when we are looking at the pathophysiology. The main feature is sudden onset of pain of varying severity, usually involving the bones, sometimes associated with swelling and tenderness because of the pro-inflammatory cytokines or molecules that are released during the crisis. There may be no history of predisposing factors, as we said earlier. Briefly evaluate patient within 5 minutes, administer analgesics, and allow an appropriate interval for pain to subside before full assessment. Ensure adequate hydration. For children, you give 100 to 120 ml per kg per day. For adults, you give about 1.5 ml per meter square per day, or 3 liters on the average. Within 12 to 24 hours. The 5% dextrose in water or dextrose saline is preferred. Hypertonic fluid such as 10% dextrose should be avoided. So this is how to assess pain. The pain can be graded as mild or moderately severe. There are the various tools of assessing the pain score. We have the Wagner-Berger tool, and then we have the pain can be where the pain can be assessed through from mild, can be classified as mild, moderate, or severe, or the pain can be scored from 0 to 10, where 0 is no pain, and 10 is the severest form of pain. In between, we have 3 to between 1 and 3 as mild, 4 to 6 as moderate, and 7 to 10 as severe. For children, it may be difficult to use verbal responses to assess the pain. Usually, we look at there's the picture form, where you look at the facial grimace and activity of the child, to assess the pain. So for moderate pain in adults, tablets, we can use the oral analgesics such as dihydrocodeine 30 milligram 4 hourly plus paracetamol 1 gram for hourly. That this can be used intermittently. And then for children, we can also use paracetamol, ibuprofen, or dihydrocodeine too. For moderate to severe pain, for adult, we can use diamorphine, 2.5 milligram to 5 milligram subcut, 4 hourly, or morphine. We can also use intermittently diclofenac in combination with diclofenac, and then, or we use diclofenac with tramadol, intermittently. Injection of opiates, diamorphine, 10 to 20 milligram subcut, 2 to 4 hourly, or opiates, e.g. pentazocine, 30 to 60 milligram at hourly. So this is a continuation of the moderate to severe pain. So oral morphine or diamorphine, and then we have for maintenance, we use slow release morphine, 1 milligram per kg, rounded up to 5 milligram 12 hourly with oral morphine, 0.3 milligram per kg, 3 hourly as necessary. Or we can use pentazocine at appropriate.
Dr. Hezekiah, please unmute. Unmute, you are muted. Dr. Hezekiah, kindly unmute yourself, please. Can someone let Dr. Hezekiah know that he's muted?
I'm doing that, ma. I'm doing that. Good morning,
Okay.
ma.
Can you hear me?
Sir.
Yes, we can.
Okay, you can hear me now. Okay. Okay, thank you. So while we do this, it's important we continue to monitor the patient closely, assess pain relief every 15 to 30 minutes, give antiemetics if indicated, chlorperazine 250 microgram per kg TDS, or cyclizine 12.5 to 25 milligram TDS. This is important because some patients, they react to some of those analgesics, especially the opiates, dihydrocodeine, or the tramadol, for example. Many, quite a number of patients react to it by, it induces nausea and vomiting for some patients. Monitor pain, sedation, vital signs, respiratory rate, because we know that morphine suppresses respiration. Oxygen saturation, every 30 minutes should be monitored until pain is controlled and patient is stable. When the patient is stable, we can begin the monitoring at every 2 hours. If respiratory rate is less than 10 per minute, omit the next dose of opiates and give naloxone 10 microgram per kg IV, followed by 100 microgram per kilogram. Discharge patient when pain is improving or control with reduced dose of oral analgesics. Arrange for home or outpatient follow-up appointment as applicable. Blood transfusion in vaso-occlusive crisis. Indication include, because I mentioned earlier that sometimes patient could have crisis, vaso-occlusive crisis, and at the same time has aplastic anemia also, and aplastic crisis, or other conditions that would have led to marked or significant drop in the hemoglobin level. So if the hemoglobin level is less than 6 grams per deciliter or greater than 2 grams below steady state value, or there are acute features of severe anemia, patient will benefit from blood transfusion. The type and determine the amount of blood, red cell concentrate raise to steady state level for adults, give 10 mils per kg for children, or you give sedimented red cells for adults to raise it to the steady state of the patient by giving 15 mils per kg. If it is whole blood, you give about 20 mils per kg to raise the hemoglobin to the steady state level. Treatment of infection. If through the assessment you identify that this crisis, vaso-occlusive crisis, is triggered by infection, we need to treat the infection. And features of infection, of course, include fever. In that case, we send relevant samples for microbiology and start broad spectrum antibiotics, depending on the common organisms in the environment. Give the appropriate broad spectrum antibiotics pending when the blood culture results will come out. Give anti-malarial in malaria endemic zone. And we have sequestration crisis. This is pulling of a large proportion of blood in the spleen or liver. It usually occurs in children less than 6 years and in some hemoglobin SC or hemoglobin S beta thalassemia thalassaemic adults. It rarely occur in hemoglobin SS adult. It is a major cause of death in children with sickle cell disease below 2 years. It rarely occurs in adults because we know by adult age, there is autosplenectomy. So they hardly have that complication. We can also have sequestration in the liver too, hepatic sequestration. So we should note that. So features of sequestration crisis include marked pallor, precipitous fall in hemoglobin, in the hemoglobin level, very sudden drop in the PCV or hemoglobin level. Patient will, if the patient is light in complexion, you could see a patient just becoming white within a very short time. Sudden progressive enlargement of the spleen, leading to increase in abdominal gap. And the patient could actually go into hypovolemic shock due to reduced circulating volume. The spleen can actually pull a very large amount of blood. So patient can have hypovolemic shock. Reticulocytosis and nucleated red cells can be seen in the blood film. Treatment of sequestration crisis, rapid transfusion of whole blood or red cell concentrate, 10 ml per kg for red cell concentrate or 15 ml per kg for whole blood. However, this should be done very cautiously. Rapid, you quickly do the transfusion, but it should be cautious, especially in terms of the amount, the volume of blood you transfuse. Because in sequestration crisis, the blood is still there in the system. It's just that it is trapped or sequestered in the spleen. With time, if the triggering factor is removed, that blood will be released back to the system. So if we transfuse too much blood, by the time the blood is released from the spleen, the patient can have circulatory overload and can lead to circulatory cardiac failure. It can lead to cardiac failure. Exchange blood transfusion may be done. This is actually better because you are taking blood out and giving another blood. So the tendency to have circulatory overload is minimized. Prevention of sequestration crisis involve teaching parents, school teachers, and caregivers how to palpate for enlarged spleen or liver. It helps in early detection and reduces the mortality rate. Elective splenectomy can be done after 2 episodes of sequestration crisis occurring within 6 months or less than 6 months apart. Sickle cell aplastic crisis. This is an acute form of acquired red cell aplasia caused by DNA virus, parvovirus B19. Parvovirus B19 replicates inside immature red blood cells in the bone marrow, resulting in severe anemia. So they go to infect the erythroblast, and right there in the bone marrow, as the red cells are being synthesized, they are being broken down because the parvovirus is replicating in them and resulting into hemolysis of the erythroblasts right in the bone marrow. Features of a plastic crisis include weakness and easy fatigability. Of course, the features of anemia, headache, fever, facial erythema, low hemoglobin, gradual fall in hemoglobin. So this is in contrast with the sequestration crisis. In sequestration crisis is usually sudden drop in or fall in hemoglobin. But in aplastic crisis, the fall in hemoglobin is gradual over days. And there's reticulocytopenia. Unlike in sequestration crisis, you can actually have some reticulocytosis, but in aplastic anemia, because the red cells are not even coming out at all, you have reticulocytopenia. Leukocyte and platelets count may also be reduced. serum immunoglobulin N M antibody to parvovirus B19 virus in the blood will be high. So for aplastic crisis, treatment include isolation of patient, especially from expectant mothers, to reduce their risk of fetal infection. Transfuse blood with a target to achieve the patient's steady state hemoglobin level. Intravenous immunoglobulin should be given to immune deficient patients. For prevention, give vaccination of non-immune individuals who have sickle cell disease or other chronic hemolytic anemias. So this is briefly about the major acute complications. We've mentioned other acute complications such as the acute chest syndrome, priapism. Those are also acute complications that patient can present with. And usually when we are managing the stroke, acute chest syndrome, priapism, we need to do it in collaboration with the relevant specialists. Like for stroke, we may need the attention of the neurologist, and for priapism, we also may have to involve the urologist. For acute chest syndrome, usually we do, and for stroke, acute cerebral syndrome, usually exchange blood transfusion is the mainstay of treatment. And even in some cases of priapism too, the exchange blood transfusion is the mainstay of management. And we need to collaborate with the appropriate specialists in these areas. So we'll now move to chronic complications, and there are quite a number of them. Depending on the system, as we mentioned yesterday, almost every organ system is affected. All the systems, all the organs can be affected by sickle cell disease. So we start with avascular necrosis of the bone. This is usually due to repeated vaso-occlusive crisis occurring at the joint or in certain parts of the bone, usually where there is the arterial supply or blood supply is there's anastomosis. There is there's no alternative blood supply to such joints. Those are the joints that are at risk of becoming of developing osteonecrosis. Usually the head of the femur is a very common target of avascular necrosis, and other joint points can also be affected. So in evaluating these patients, we need to get an X-ray of the joint, and also sometimes we may need an MRI early in the course. Management include counseling a patient to minimize movement and bearing heavy weight on affected joint, especially at the earlier stages, in order to reduce the progression of the osteonecrosis. Administer analgesics, non-steroidal anti-inflammatory agents, plus or minus opiates, depending on the severity. Refer for orthopedic assessment, treatment, and for surgical management if indicated. Give disease-modifying therapy such as hydroxyurea to prevent progression or involvement of other bones. So for this chronic complication, as I mentioned earlier, the multidisciplinary team management is very, very important. So the earlier, the better. We send them to the appropriate specialists who will evaluate them further and give the necessary intervention. Chronic leg ulcer is also another common chronic complication of sickle cell disease. We manage this first by assessing the wound and documenting the size, appearance, status of the surrounding skin, presence of tenderness, whether there is edema, and we also look for lymph nodes involvement depending on the area. For the avascular necrosis of the head of tumor, we check for lymph nodes in the femoral lymph nodes involvement. Do full blood count and blood if associated with cellulitis or abscess formation, fever, and bone tenderness. Yeah, some patients will actually come with with infected ulcers, sometimes even foul smelling and discharging, and we need to do take a swab and do culture, and sometimes we need to even take blood for blood culture when it has become systemic. Do imaging studies, e.g. X-ray, MRI, to exclude osteomyelitis. Take biopsy for histopathology when malignancy is suspected. Yeah, for some of them, because of the chronicity, and continuous irritation, some of the of these ulcers can actually transform into malignancies. So in that case, a biopsy, a skin biopsy, should be done. Apply graduated compression bandages to reduce lymphedema. Elevate feet when sitting to improve blood circulation to the ulcer. Apply wet to dry dressings twice a day, depending on how bad the leg ulcer is. Some may require twice daily wound dressing. Consult the surgical team for surgical debridement and skin grafting when indicated. So, as we mentioned, multidisciplinary team management. The plastic surgeons, if they are available, patients should be referred to them for management, and give zinc supplementation, because it has been found that some patients with chronic leg ulcer have low zinc levels. So zinc supplements may help because the zinc helps to stabilize the red cell membrane, reducing hemolysis that can subsequently lead to leg ulcers. If there is associated pain, treat the pain with adequate and appropriate analgesia. Usually the pain is neuropathic in nature and is treated with amitriptyline. Consult vascular surgeons if features of arterial insufficiency are present. Consider regular blood transfusion until the wound heals if the above measures fails. Also consider discontinuation of hydroxyurea in patients with non-healing or slowly healing ulcer. Very rarely you see some patients that their wound ulcer is actually being worsened by hydroxyurea if they are on hydroxyurea. So in that case, we may have to discontinue the hydroxyurea, but this is very rare. Explain to the patient that the ulcer may take long time to heal. So treatment of leg ulcer could actually be very frustrating, difficult to heal, especially if the triggering or the risk factors are not identified and removed. Some of the risk factors include, too much, standing, trekking, is common among young people that are very active. Some of them, if they are involved in trekking long distances, maybe to school or to work, we have instances like that. Some of them that are students during long vacation, you see that the wound is actually decreasing in size because maybe they are doing less trekking. We also had a case scenario. One of the case scenarios, it was a young lady. She has never had a leg ulcer, but when she got employed as a primary school teacher, because of prolonged standing to teach, she developed a leg ulcer, and we are struggling to manage it. So when it improved and was almost healing, the school resumed again, and she now went back after holiday, and the leg ulcer broke down again and started expanding. So those are some of the risk factors that could be. So patient education is very important, and the patient should know that it could actually take some time. Some of them is because they have very low PCV, hemoglobin level. And if they have very low hemoglobin level, it will be difficult for that wound to heal. So sometimes you may have to combine with top-up transfusions, to assist in the wound healing. Cardiac complications. For this, we assess all patients for cardiac symptoms, which include dizziness, chest pain, ankle swelling. Perform cardiac examination that includes assessment for signs of right heart strain at each annual review. Patients with cardiorespiratory symptoms and signs should be evaluated with electrocardiography, ECG, and echocardiography. Echocardiography should be repeated annually in patients with previously elevated trioscopic regurgitant velocity who have not had right heart catheterization. Right heart catheterization is a special investigation that is used to confirm pulmonary hypertension. And it's usually not available at most centers. So if in the absence of it, we need to be repeating the echocardiography to check for this for this complication, on an annual basis. Refer patients to a pulmonary hypertension specialist for consideration of right heart catheterization if the TRV is greater than 290 centimeters per second or is between 250 to 290, between 250 and 290 centimeters per second. Chronic hypersplenism. So to do complete blood count or full blood count, reticulocyte count, and peripheral blood film. Monitor spleen size and document at every clinic visit. Exclude and treat other causes of cytopenias. Do splenectomy if hypersplenism is associated with failure to thrive or chronic pain, and when hemoglobin and platelets are persistently less than 5 grams per deciliter and less than 50 times 10 raised to power 9 per liter respectively. Give penicillin for a minimum of 3 years post-splenectomy. So this hypersplenism is exaggerated function of the spleen, usually in children. This is it falls short of the sequestration crisis. There is chronic pooling of blood in the spleen, but not to the extent that it will give us sequestration crisis. So the patient persistently and continuously have low blood counts, anemia, low platelet count, less than 50, on a persistent chronic basis. That is hypersplenism. Hello, can you hear me?
Yes, please,
Yes,
we
sir.
can.
Okay. Sorry, my slides are not moving. I
Your
hope.
slide just went off. Is it everybody or only me?
No, I just off it because I cannot move them. So I
Okay,
hope
okay.
it will not be like yesterday. Let me reshare again.
Dr. Aniago, please get in touch with me now. Thank you.
Okay, ma.
Mhm.
Dr. Issa, sir,
I think he's
are
off.
you able to reboot?
He's not. He has not joined it. He has not.
He has not
rejoined.
joined back.
Mm.
Okay. Let's be on the lookout for him. In the meantime, please, everyone should make sure that they have done the pretest. If you were not able to do it yesterday, or you are just joining us this morning, it is important that you do the pretest. That is your eligibility criterion for continuing in the program. Please do the pretest now. Again, the attendance is already activated. Please go to the post, go to post in more, post and quizzes. In more, when you click on more, you will get post quizzes. Click on post and then fill in your information. Thank you very much. Madam Ijoma, can you help us reach out to Dr. Issa?
They say we should do this. Yes, sir.
Sorry, Dr. Hezekiah is still trying to fix the slide. It's frozen. That's why we are waiting. But in the process, as many people as have not done their pre-test, you please go ahead and do it. Thank you.
Mm.
Okay. Dr. Isa is back now.
Sorry for
Yes, I
the
can see the slide now,
glitch.
please.
Sorry for this glitch. So I think we were at this point talking about chronic hypersplenism. So if a patient, if splenectomy is indicated when the platelets count are persistently less than 5 grams, I mean the hemoglobin is persistently less than 5 grams per deciliter, or platelets counts are less than 50 times 10 raised to power 9 per liter. Splenectomy is indicated because we know that sequestration is a very deadly complication. Many is a common cause of death in sickle cell disease children. So, and following splenectomy, we give penicillin for a minimum of 3 years post-splenectomy. So for chronic pain is considered if pain lasts more than 3 months. It should be chronic. It could be chronic pain with objective signs. That is due to somatic. It could be somatic due to organic. It could be organic, maybe such as avascular necrosis or chronic leg ulcer. And it could be due to neuroplasticity of the peripheral or central nervous system. In this case, sometimes the ulcer, leg ulcer would have healed, but patient will continue to have neuroplastic pain. So we need to assess that to know the kind of pain. Assessment include looking at the location, severity, factors that precipitate or relieve it, including psychosocial factors, and it is effective on the patient's mood. I mean, its effect on the patient's mood, activity, employment, and quality of life. Evaluate the patient's response to treatment. That is the pain relief, side effects, and functional outcomes to guide treatment. Assessment for chronic pain should be done annually. So usually, sometimes it may involve asking the patient which pain relief drugs, medications actually work for him or her, you know. So you assess the patient wholly. So management, use long and short-acting opiates to manage chronic pain that is not relieved by non-steroid, non-opiates. Encourage the use of deep tissue pressure, massage therapy, muscle relaxation therapy, and self-hypnosis. Neuropathic pain. For neuropathic pain, you treat by antineuralgic or tricyclic antidepressants, e.g. amitriptyline. So these are the modality of treatment. There is actually non-therapeutic forms of or non-pharmacological treatment, like the massage, self-hypnosis, and so on, and so forth, that can be used to manage this pain. And sometimes we may have to involve the mental health people. You can refer to the psychologist if there is associated anxiety or depression. Patient with progressive musculoskeletal conditions should be referred to orthopedic or rheumatology specialists. Refer to occupational therapists and physiotherapists to assist patients to gain optimal physical function and independence. Endocrine complications. As we saw yesterday, the endocrine organs can be affected by sickle cell disease. And most of the time, patients that have chronic transfusion, they develop transfusion iron overload. And this iron is usually deposited in vital organs such as the liver, the endocrine, even the heart, so, and this can lead to hypofunction of these organs. So measure for gonadal dysfunction, there is low testosterone. Measure weight and height and plot on an appropriate growth chart. Screen levels of testosterone every morning to early morning total testosterone, and 2 separate readings before 10 a.m. If at the age of 14 years in male patient there is evidence of hypogonadism, refer to an endocrinologist for further evaluation and treatment. Actually, in both, in male patients. Adrenal dysfunction. Evaluate patients who have hypodynamic compromise during sickle cell crisis with sepsis or adrenal insufficiency. Refer to endocrinologists if there is evidence of adrenal insufficiency. For affectation of the thyroid, if there is thyroid dysfunction, check for a history of chronic transfusion, which is a recognized risk factor associated with thyroid dysfunction, as we mentioned earlier, and refer to endocrinologists. Impaired glucose tolerance tests. Perform annual glucose tolerance screening with fasting plasma glucose in chronically transfused sickle cell disease patients because of the risks of iron overload. Refer patients with impaired glucose tolerance tests or diabetes mellitus to an endocrinologist. Parathyroid dysfunction. Screening with screen the patient for serum calcium, phosphorus, alkaline phosphatase, and parathyroid levels. Do neck ultrasound to exclude parathyroid enlargement. Screen for hypothyroidism in chronically transfused patients from the age of 10, and refer patients with evidence of parathyroid dysfunction to the endocrinologist. Then we have chronic sickle cell hepatopathy. This condition, this could be it's a spectrum. This could be cholelithiasis, that is gallbladder stones, cholelithiasis, the stones are lodged in the biliary ducts. Then sickle cell cholangiopathy and transfusion iron overload can also lead to cirrhosis. So these are the hepatopathies that can be found in sickle cell patients. Evaluation includes doing a liver function test, abdominal ultrasound, clotting profile, endoscopy, liver biopsy, and if there are any abnormalities, you refer to hepatologists. Viral hepatitis. Increased risks there's an increased risk of having viral infection in sickle cell disease due to blood transfusion. Also depends on the prevalence in the community. Refer to hepatologists. Monitor hemoglobin concentration. Then patients can also have ophthalmic complications, which include proliferative sickle retinopathy, and this is usually due to repeated vaso-occlusion and ischemia in the retina, leading to the release of factors that promote vessel formation. Refer a patient with proliferative sickle retinopathy to an ophthalmologist for evaluation and possible laser photocoagulation therapy. Refer children and adults with vitreoretinal complications of proliferative sickle retinopathy to that is refractory to medical treatment for evaluation and possible vitrectomy. Conduct psychological assessment for psychological complications. Conduct psychological assessment for all patients routinely. Conduct neuropsychological assessment when neurological complications or educational problems are indicated. Assess the mood.
What did you take all of them now?
No, I'm not taking all.
Emotional problems. Assess mood and emotional problems. Assess physical and social function. And assess coping strategies in relation to pain, symptoms, and complications. Also assess general health and related quality of life. There are actually tools for this assessment. So once in a while, maybe on a quarterly or annual basis. We use this assessment as a tool, tools to assess the psychological state of the patient. Also assess attention, concentration, and executive function initially, followed by comprehensive neuropsychological assessment. Offer psychological therapies, e.g. cognitive behavioral therapy, individuals and or group or family sessions as appropriate. So sometimes the patient and his caregivers may have this cognitive behavioral therapy because once there's a member of the family is affected with sickle cell disease, the other family members are indirectly involved. And if the therapy is done together with them, they can, together with the patient, help in implementing such therapies that will give a better outcome. Suggest available psychological safe resources, including internet-based interventions. Liaise with schools and colleges to negotiate additional or special educational support to compensate for neuropsychological complications and poor school performance. Another chronic complication that can be seen in sickle cell disease is pulmonary hypertension. Screening tests include echocardiography or measurement of N-terminal brain nitriuretic peptide, or an 6 minutes walk distance. If pulmonary arterial pressure is greater than 40 millimeters of mercury, or trioscopic regurgitation jet velocity is greater than 2.5 centimeters per and 2.5 meters per second, or the N-terminal pro-brain nitriuretic peptide is greater than 164.5 picogram per mil, and or the 6 minutes walk test is less than 333 minutes. Confirmatory tests should be conducted. And this confirmatory test is right heart catheterization. Fortunately, it is not commonly available, but patients can be referred to centers where it is available, or should be referred to pulmonary hypertension specialists. Treatment: if the mean pulmonary arterial pressure is greater than 25 millimeters of mercury, refer to a pulmonary hypertension expert for treatment using target therapies such as prostacyclins analogs, phosphodiesterase type 5 inhibitors, or endothelin receptor antagonists. Renal complication. There's a spectrum of renal complications that can occur in sickle cell disease. If there's microalbuminuria or macroalbuminuria is identified, if this is identified, order a 24-hour urine test for protein. Refer people with proteinuria of greater than 300 milligrams per 24 hours to a nephrologist for further evaluation. For adults with proteinuria without other apparent cause, initiate SA inhibitors therapy, that is angiotensin converting enzyme inhibitors. For children with microalbuminuria or proteinuria, consult a nephrologist. Consider patients with modest elevation of serum creatinine greater than 0.7 milligram per deciliter in children, or greater than 1 milligram per deciliter in adults, to have a renal impairment, and refer to a nephrologist for further evaluation. Give ACE inhibitor therapy for renal complications when indicated, even in the presence of normal blood pressure. Renal replacement therapy, hemodialysis, peritoneal dialysis, and renal transplantation should be used in sickle cell disease if needed. Nocturnal enuresis. This is also a complication of the renal system. Routinely ask patients about nocturnal enuresis in the child with sickle cell disease at 6 years and older. Document presence of enuresis and give information to parents and other caregivers. Assure patients that nocturnal enuresis is a known and common complication of sickle cell disease. In fact, quite a number of patients have this, even patients without sickle cell disease. So it will be important to assure the patient that it can occur, and with time, it may it may reduce.
He was studying at the random window.
No, because I did it.
Investigate presence of snoring,
Wait.
possible obstructive sleep apnea, and nocturnal hypoxemia. If these are present, refer child to ENT surgeons for further evaluation and management. Refer child to enuresis management program if one exists for training in use of enuresis alarms, and provide family counseling to avoid punitive measures that further lower the child's self-esteem, and do not withhold fluid intake in management of enuresis in children with sickle cell disease. Chronic neurological complications can also occur in sickle cell disease. Evaluate children and adults who present with new onset seizures for acute stroke or evidence of cerebrovascular disease. Evaluate children and adults who present with new seizures and no evidence of stroke for other causes of seizures such as epilepsy. Consult with neurologists to manage chronic recurrent seizures with appropriate anticonvulsants. Do not give meperidine or petidine to people with sickle cell disease who have a seizure disorder, because its metabolite, normeperidine, is a neurotoxin which is associated with seizures. So it can worsen the seizures if given. Then priapism, stuttering or recurrent priapism. Clusters of self-limiting episodes of priapism can occur in sickle cell disease. Take a history of frequency and duration of erections and examine the phallus. Do corporal blood gas analysis and corporal Doppler ultrasound. Management include instituting simple measures such as bladder emptying, hot bath, hydration, adequate analgesia, which could be non-steroidal or anti-inflammatory agents or opiates, and gentle exercise. Consult urologists if not detumescence after 2 hours for evaluation and possible surgical intervention. Prevention includes giving slow oral epinephrine, starting with 25 milligram daily nocti. If there is no satisfactory response, increase dose by 25 milligram every 2 weeks to a maximum of 100 milligram in divided doses, or oral pseudoephedrine 30 milligram nocti in children of less than 10 and 60 milligram nocti in children and adults children greater than 10 and adults. Consider the use of hydroxyurea educate male patients and patients of adolescent, educate male patients and parents of adolescent patients about the risks and the emergency nature of priapism, safe treatment measures, and to seek medical help if episodes exceed 2 hours. So in summary, we've looked at both acute and chronic complications, and we've seen that complications can involve every organ of the body, and we've emphasized at each point that multidisciplinary management is very important and it gives a better outcome. The aim is to identify these complications early and to institute interventions early, and so that patients will have a better outcome and a better quality of life. Thank you for listening.
Wow, thank you very much, Dr. Issa, for this really expository lecture on complications and management, extensive management of sickle cell disease. By now, people should have dropped their questions in the chat box, but I will bring back a question asked last night about the role of genetics in the treatment. Someone asked that question, and I said they should wait till you come again. So, sir, do you want to say something about that?
Sorry, the role of
genetics.
Genetic modification.
Or genetic modification.
Okay.
I'm sure the person is talking about gene editing.
Yeah, this is actually the ultimate, because it is actually a genetic disease if we remember the pathophysiology. So genetic modification in terms of gene therapy, that is ultimate. And then we have bone marrow stem cell transplantation. Those are ultimate. But we can also do that with pharmacologically using hydroxyurea. Hydroxyurea is a disease-modifying agent, that sort of, it will not really alter the gene mutation that has occurred and that is causing the problem and complication. But what hydroxyurea does is that it increases the fetal hemoglobin. The level of the fetal hemoglobin, and so there's the ability of the red cells to deliver oxygen better, and as a result, it will lead to decrease in the complication. Hydroxyurea also helps in cellular hydration. We saw the role of cellular dehydration yesterday. Hydroxyurea is also known to improve red cell hydration. So by this form of modification, patient can do better. But the ultimate is gene therapy, going to actually correct the gene mutation that occurred and led to sickle cell, the sickle cell disease. Thank you. I don't know whether that answers your question.
Thank you very much, sir. The questions are coming now. Somebody just asked, how do we deal with sickle cell patients getting more addictive to analgesic medications due to the persistent pain?
Okay.
So how do we curb addiction?
Okay. So again, here multidisciplinary management is important. We need to consult with the mental health physicians, the clinical psychologists, and the mental health and the mental
Please mute
health
your
decision.
microphone.
So we need to consult with them, and we may need to refer the patients to them for rehabilitation.
Thank you very much, sir. Somebody is asking if you can throw more light on the sequestration.
Okay,
from last night. And I think you have also said something about the second question on the use of hydroxyurea. And so the person is asking about the dosaging. How can the dosage be calculated, as well as sequestration from last night's presentation? Over.
Okay. The sequestration crisis, we know that that the spleen plays a function of is a reticuloendothelial system. Quite a large volume of blood passes through the spleen for various, and then as it passes, the vascular supply of the spleen is in such a way that it can call or pits, any inclusion or abnormality or that is found in the red cell, and then abnormal or the senescent or old red cells are removed in the spleen. But sometimes, especially in the sickle cell patients, if there are infarcts in the spleen, it can disrupt this function. And blood, once it gets to the spleen, it may not go out. It may not be released, and then it gets sequestered in the spleen. That is what happens, and it can lead to sequestration, especially in children below the age of 6 years. So that is what happens in sickle cell in sequestration crisis. So we've seen that one of the main modality of treatment is exchange blood transfusion. One, and then we can also have ordinary transfusion with red cell concentrate or sediments.
I say I will put my earpiece in the. That's what is.
We mentioned that this should be done consciously, because with time, the blood will be released into the circulation. So, and talking about hydroxyurea, we just mentioned that hydroxyurea is a disease modifying factor. In terms of the dosage, it is usually given between 15 to 25 milligram per kilogram, and sometimes even up to 35 milligram per kilogram of body weight. So that is how to calculate the dose. And usually you start with the lower doses. Maybe when a patient is coming, you start with 15 milligram per kilogram body weight, and then you monitor the patients in terms of improvement of the hemoglobin, and also in terms of other complications too, because hydroxyurea can suppress the other red cell count. It can suppress the white blood cell count. It can also suppress the platelet count. So you monitor, and then if the hemoglobin is not improving well, you can increase the dosage. Instead of using 50 milligram per kilogram body weight, you can increase it to 20 milligram per kilogram body weight. you continue to monitor. The aim is to get to a point where you have like 10 milligram, 10 grams per deciliter of hemoglobin. If you are able to achieve the point at which you are able to achieve a hemoglobin of 10 grams per deciliter or a PCV of 30%, you maintain the patient at that dosage. So that is how to calculate the dosage.
Thank you very much, sir. I will take these two questions together. Somebody is asking about the continual use of analgesic causing hepatic-related diseases. So how do we deal with this? The second one is how do we make...
Sorry, I didn't get the first one.
Let me read it as it is written. The continual use of analgesic can cause hepatic-related disease. How do we deal with this?
Okay.
That's one. The second one, how do we make diagnosis of pulmonary hypertension in sickle cell anemia patients in centers where we cannot do cardiac catheterization?
Okay. So the first question is saying that continuous use of analgesic can lead to hepatic complication.
Related
Am I right?
diseases or problems, yes.
Yes. So, but I don't think that statement is completely correct. It depends on the type of analgesic, and it depends on the dose of that analgesic. So it depends. Like paracetamol in particular is hepatotoxic if it is used in very, very high dosages. Then it's not only the liver that can be affected, even the kidneys can be affected by use of some non-steroidal anti-inflammatory agent on a chronic basis. So that as we are using these medications, we are also monitoring the patients to avoid such complications. And then not only the kidneys, but the GIT too can also be affected by chronic use of analgesic, especially the non-steroidal anti-inflammatory agent. They can cause gastric erosion and cause peptic ulcer disease. So use of analgesic should be cautious, and we should always monitor and check out for these complications. So the second question
is about how to diagnose pulmonary hypertension.
Okay, pulmonary hypertension. Of course, as we mentioned earlier, if you are does cardiac facilities for right heart catheterization, we will refer to those centers where it can be done, and once it is done, usually it's done by the cardiologist. Once they make the diagnosis, they continue to treat, because if you are not a cardiologist, you may not be able to treat it well. So they make the diagnosis, you refer the patient to them, they make the diagnosis, and they take over management, of the complication itself. Of course, you continue to co-manage the patient as a hematologist or as a physician with them for the other complications.
Thank you very much, sir. Our time is fast spent. This is 4 minutes past 9, but I will take these last two questions that are asked on pharmacological issues. Somebody is asking if morphine can be used together with pentazocine in the management of patients with severe form of VOC. and what's the dose of morphine, both oral and IV. The second one is somebody's concerned about other ways through which sickle cell disease can be cured, maybe through another form of genetic mutation or the use of contemporary technologies. This will be the last questions for today because of our time. Thank you, sir.
Okay. As we mentioned earlier, the for cure, the modality is stem cell transplantation. You know, you achieve cure, or gene therapy. You know, and gene therapy is a technology that you use to modify or to correct that mutation that occurred. You know, and patient will begin to produce normal hemoglobin AA red cells. So that is that about the cure. Those are the modalities that you can use for cure. Then, sorry again,
possibility of using combining morphine with pentazocine.
Okay, so for morphine and pentazocine are not a good combination. They are both centrally acting analgesics. They are opiates. You know, if you the idea of using combination therapy when you are combining drug, not only for sickle cell disease, whether antibiotics or antihypertensive, the idea is to use drugs that have different mechanism of action so that they can act synergistically or synergistically to complement each other to achieve more effect. So morphine and pentazocine, they are opiates, they act centrally, so it will not be advisable to use the two at the same time. Usually, you combine morphine with non-steroidal anti-inflammatory agent or pentazocine with another non-steroidal anti-inflammatory agent. So that is the idea. So if it is severe pain, you know, you go for morphine with maybe another, maybe diclofenac, whether suppository or parenteral. Then, or if morphine is not available, you can use pentazocine with another non-steroidal anti-inflammatory agent. So that is the idea.
Thank you very much, Dr. Issa, for this extensive, expressive, and highly stimulating lecture on sickle cell disease complications and their management. Thank you so much, sir. We appreciate you. And I want to tell everyone that this is just the beginning. He has touched on some topics that will still be really taken into details in the course of this program. We have 3 weeks more for the virtual interaction. So we will be having a lot about genetic counseling itself and how to inform patients about all these things, the way they will understand and get feedback and do diagnosis and do community engagement and do everything that you are thinking about. So for people asking about health education or premarital education, all of this will be taken extensively. We'll be talking about newborn screening as time goes on. We will still come back to pediatric management, specifically in sickle cell disease. We will talk about the ethical, legal, and social issues which will bring about the cultural issues and all the issues revolving around sickle cell disease in the community, with discrimination and stigmatization and all the issues that we can think about. All of this will be well taken care of in the course of this program. So be patient and make sure that you join every time. Attendance is very important. If you have not signed in your attendance today, please do so. If you have not done pre-test yesterday or today that you joined, please do it now. Today is the last opportunity. We won't be talking about pre-test any longer. And if anyone does not do pre-test, they are not eligible to continue in the program, not to even talk of doing the post-test, because it won't matter, it won't count. So please do that. Yesterday, when the MPI was speaking to us, Professor Priska Adejumo, she particularly touched on one important matter, and that is about the reimbursement for data. Please take note that we are only paying for part of the data. We are not sharing money. We are not sharing money to anyone on this program. This program, if you want to do this type of course elsewhere, you know you have to pay heavily. Nobody is asking you to pay anything. Please don't let's go to the extreme of fighting about money. We are not sharing money. We are only going to reimburse you, give you a token for the data that you have used at the end of this program. And that is why it is important to make all the sessions. It is very, very important from the beginning to the end. And I pray that God will help every one of us. So for today, we are grateful that we were able to complete the overview and the management of sickle cell disease, all thanks to our associate professor, Dr. Hezekiah Issa, who has done justice to this topic since yesterday. Thank you very much, sir. So on this note, I know that people have been agitating about the evaluation. I've not seen it posted. If we don't have it posted today, by the time we have the platform on Monday, it will be dropped on the platform so we can all feel it before the next contact session next week. Remember that this is a weekly event. Friday in the evening, Nigerian time, 8 to 9 p.m. and in Ghana, 7 to 8 p.m. And again on Saturday morning, Nigerian time, 7 to 9 a.m. and in Ghana, 6 to 8 a.m. We want to thank every one of you beautiful people that have found time to join us at this time and that stayed through in spite of all the technical glitches. We want to thank you so much and pray that God bless you as you continue your day. Professor Adejumama, do you have any parting word for us?
Nothing.
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 Thank you very much, ma. So people can log off and go about their weekend activities. Happy weekend to all of us. Let's make it a date next week again. God bless you.
Thank you, ma. Happy weekend to you too.
Happy weekend, ma'am.